some more important areas, but not everything about plastics. So let's start with the acute burn management. So any of you have not had the plastic module attachment, or every one of you has saw this management of burn PowerPoint before? Hello, can someone reply me? Can somebody reply? Have you ever seen this PowerPoint before?
I think we had a burn tutorial, but I don't think we used this exact PowerPoint.
That means every one of you had the tutorial on burn management. Did you? Okay, somebody said they haven't. So we'll start with the burn management. So the principles of burn management depends on stopping the burning process and rapid and accurate assessment of the injury extent, then early and appropriate intervention in order to save life and function. And at the same time, prevent complications and promote early return to pre-injury functional status. So we'll start with history taking for every burn patient. You need to know the exact mechanism of the burn injury. Is it a thermal burn, chemical burn, electrical burn, or something else? The time of contact, the longer duration, obviously, the worse will be the injury. Is it an accident, or is it an injury on duty, or an assault, or a non-accidental injury? Where did the burn happen is particularly important for any flame burn because it poses a worry about inhalation injury. And when did it happen? Is there a delayed presentation to medical care? We wish to know if there is any first aid done, any treatment received before the presentation, like did they apply any ointment or something that they would think would work for the burn, and the age and the background history of the patient as well. So in our practice, we follow the EMSB guideline for management of severe burns. That is a very standardized protocol like the ATLS, and this shows how it's structured. So we'll start with the airway, breathing, circulation management and check for any disability and exposure of the patient. Then adding a block of FATT, namely fluid anesthesia tests and tubes, that will complete with a secondary survey like the ATLS. So for primary survey, the airway management with C-SPAN control, we give oxygen supplement, check the circulation with control of the hemorrhage and set into large ball of cannula, preferably over the unburnt area. Then disability, check AVPU and exposure with environmental control, namely the temperature control for a first wound assessment. For airway, same as all trauma cases, but we are particularly alert for any suspected inhalation injury. So intubation is only by experienced and trained doctors. If the different hospital, the airway expert could be different. Sometimes they could be the anesthetist, sometimes the ICU doctors, sometimes the ENT colleagues. So you have to get yourself familiarized with the setting where you work in. So an inhalation injury, the history particularly is burned in enclosed space or explosion. But of course, even the patient is burned in open area, you still have to ring the bell if any of the physical examination signs are elicited, like facial burn, burned face hair, like over the nose or the brow. They're coughing out sputum. They have a very drowsy cough. They have change of voice, drooling, and stridor could be very late signs. So we classify inhalation injury at different anatomical level. It could be above the larynx, namely the upper airway obstruction, and below the larynx, the lower airway injury. So upper airway is due to narrowing of the airway because of the mucosal edema, the excessive secretion, or rarely due to the external compression of the neck tissue and then constricting eschar. This could deteriorate very rapidly, especially with a large amount of resuscitation fluid being poured in, perpetuating the mucosal edema. It could be life-threatening in the acute stage of a burn case. So this is the diagram showing the inhalation injury. So upper airway, because of the hot air and steam, caused the laryngeal obstruction and bronchospasm. And lower airway, mainly is due to the irritant gas that will cause pneumonia or pulmonary edema. This is the bronchoscopic view of the vocal cords, if you could appreciate. The diagram A is before giving the resuscitation fluid, and on diagram B is after a large amount of resuscitation fluid is poured in. If you could appreciate, the caliber of the airway is significantly reduced. That means the intubation at the later stage could be very, very difficult and if not impossible. For lower airway inhalation injury, one special entity is called the carbon monoxide poisoning. As due to the product of incomplete combustion being created, the carbon monoxide, it has a oxygen binding affinity. It has a hemoglobin binding affinity 240 times greater than oxygen. So it will significantly reduce the oxygen carrying capacity of your circulation, and the pulse oximetry reading will be falsely reassuring. So you will need an appropriate blood gas reading to make the diagnosis. And the treatment is to give supportive pure oxygen. And this diagram shows the symptoms of carbon monoxide poisoning. You can see that even at the level of 30 to 40%, the symptoms could be very subtle with some headache, shortness of breath, drowsiness. It could be easily missed if you do not actively check for the carboxyhemoglobin level. So another is hydroxycyanide poisoning from burning of plastics, but these nowadays are less common. Then we will move to burn wound assessment after the airway breathing circulation is being secured. We focused on two aspects. The first one is the burn wound depth, and the second one is the burn wound area. So the depth of the burn wound, in old terms, they classify them as first, second, and third degree burns. But nowadays, we seldom use this terminology because it is a very inaccurate description of the burn injury. You can see under the category of second degree burn, it could be subclassified into superficial, mid, and deep dermal, and carry variable healing potential. So now we rename them into epidermal, superficial dermal, mid dermal, deep dermal, and full thickness burn. So for epidermal burn, the classical example is sunburn. So the wounds will heal by itself. The capillary view is very brisk with a pleasant sensation. And then moving on to superficial dermal burn, the pain sensation is still intact. There could be some blisters, and these wounds behave like epidermal burn wound. They will heal spontaneously within 2 weeks. Moving on to deeper burn involving the mid-dermal level, the healing potential could be variable. The pain sensation is still intact. The capillary view could be very sluggish. And then for deep dermal burn, they behave more or less like full thickness burn with a very poor healing potential. The capillary view could be absent. It will be very dark red in color. There could be some fixed staining. The sensation will be absent. So this diagram shows the appearance of various burn wounds. And you can see for full thickness burn wound, there could be an eschar present. So because of its varying healing potential, the scarring will be different as well. If a wound could heal timely within 2 to 3 weeks, the scarring should usually be okay. But if the wound cannot heal on time, then we have to intervene with skin grafting, and the scarring could be much worse. Then moving on, we'll talk about the area of burn. We follow the rule of 9. So in adults, for the anterior trunk and posterior trunk, each will account for 18%. Each lower limb will be 9%. Each upper limb will be 9%, and each lower limb will be 9%. The whole head neck region will be 9%, and the remaining 1% will be going to the perineum. And it is age adjusted for children under 9 years old because of their different body proportion. However, when we are calculating the area of burn, we do not include the epidermal burn. We only count for the burn that involves the dermis. So if it's just erythema, the epidermis is intact, please do not include the area of burn in your calculation. Another way to count is by the patient's perm. They will represent 1% of their body surface area. So you can use this one for a smaller burn size wound. And on your right side, there is a Lund and Barder chart. It's a more detailed calculation of the burn area. It's also age dependent. For various regions, they carry different percentage. So at this moment, concerning the depth of the burn wound and the area of the burn wound, any problems, any questions you want to ask?
Hello, doctor. I wonder for exam section and OSCE station, should we comment on like second degree burn, or should we comment on like partial thickness, superficial burn? Which one is more appropriate for exam purpose?
I said the first and second degree burn, they're out of favor nowadays. We do not use them to classify the burn.
Thank you.
Then moving on, there are some limb threatening conditions, circumferential burn. So sometimes if the burn is circumferentially encasing a limb, then the eschar will form and it will constrict and cause impairment of the distal perfusion. So in those cases, you have to check for any pain, paresthesia, prolonged capillary review, paralysis, and pulselessness are very late sign for a limb in compartment syndrome. If in any doubt, although the diagnosis of compartment syndrome is a clinical diagnosis, but if you've got any doubt, you can always measure the compartment pressure with a Stryker needle or a manometry. It's called an ascrotomy. So it could be done under local anesthesia because, as I've said, an eschar is a full thickness burn, and there is no pain sensation, and there will not be much bleeding because all the blood vessels are composed. So you can use a diaphragm to perform this procedure at bedside. We cut open from normal unburned skin to normal unburned skin, full thickness.
Sorry, Doc. The PowerPoint stopped share, and just now you cut out for a little bit. I'm sorry.
No, I will not repeat, but anyway, we'll share it again.
Okay.
So from normal unburned skin to normal unburned skin, exposing the fascia. And this diagram showed the lines of the incision and the important anatomical structures that you've got to avoid. And this is the diagram showing how a striker needle is like. We'll just put the needle tip into the concerning compartment and then inject a small amount of saline from the prefilled syringe. Then the measurement will be given by this small machine. So fasciotomy, the difference between a fasciotomy and an aspirotomy is that in fasciotomy, we open up also the fascia. So when are we doing an aspirotomy and when are we doing the fasciotomy? If the compartment syndrome is purely due to a constricting eschar, and most of the time that happens in a circumferential full thickness burn, then we will proceed with an aspirotomy. For fasciotomy, the perfusion impairment is due to the muscle swelling. It could be due to some very deep burn involving the muscle, or it could be due to electrical burn that a current passed through the muscle group, causing the muscle to be damaged and swell up, or sometimes anything? Any questions? So, or sometimes that the patient is in a prolonged position compressing on a particular muscle group, then the muscle group could also swell up. In those cases, then you will have to open up the fascia and release the muscle as well. So for fasciotomy, it has to be done under general anesthesia in the OT and inside the fascia of the involved muscle compartment to release the muscle. You may see the muscles bulging out. And this is the classical incision lines for the forearm as well as the lower limb. But I think this will be covered a bit more in your orthopedic module, so I'm not going to repeat over here. Then after A, B, C, D, E, and some limb-saving, life-saving procedures been done, then we will proceed with FATT, namely the fluid and the GCR treatment test. So for fluid resuscitation, so this slide is important. When do we start fluid resuscitation? For kids, we start when the TBSA is more than 10%, and for adults, we start when it is more than 20%. What is the formula that we use? We use the modified Kaplan formula. So it states that in the first 24 hours post-injury, we will give 2 to 4 ml per kg per percentage. So we normally start at 3 mils, but 2 or 4 are also correct answers, depending on your patient's background history and the condition when they present. So the first half will be given in the first 8 hours post-injury. So it's post-injury, not post-presentation to medical service. And the second half will be given in the next 16 hours. So our preferred solution is Hartmann solution or lactate arena, depending on the availability in various units. And for children under the age of 16, apart from the modified Kaplan formula, we will also give maintenance fluid by their body weight. So any question with this slide? This slide is important. Okay, if no question, then we will move on. So how do we monitor the adequacy of resuscitation? We'll monitor by the urine output. So we'll, for this reason, put in a urinary catheter for all major burn patients. Our aim is at least 0.5 ml per kg per hour. For children, we'll aim at 1 ml per kg per hour. So if they are having inadequate urine, then we'll try to give extra fluid to challenge and see if the urine output is improved. And then we'll adjust our resuscitation regimen accordingly. Like if we start from 3 and their response is poor, we give extra fluid for challenge. And if they improve, then we may consider adding our resuscitation fluid to 3.5 ml per kg per hour. And that really depends on different patients' response. So the key message is that you've got to go back and reassess the adequacy of resuscitation for your patient. You do not just prescribe the fluid and then let them wait for 24 hours till the regimen is completed, you've got to come back and reassess. So apart from the amount of urine, we also check on the color of the urine. This dark color urine is the phenomenon we call hemochromaturia. It's due to the presence of hemoglobin or myoglobin in urine, and they're commonly due to extensive deep burn involving muscle, high voltage electrical injury causing muscle damage, lung trauma like prolonged dependent position, tissue ischemia. These hemoglobin or myoglobin will lead to acute renal failure. And the first step is to increase your resuscitation flow rate to maximize the urine output. In adult, we aim 1 to 2 ml per kg per hour. But if these conditions happen, you have to call the ICU colleagues because these patients may need ICU support in due course. So analgesia, we give morphine for the patients for pain control, then check for the test, CBC, liver renal functions, those basic bloods. If you're in doubt of any inhalation injury, of course, check the blood gas. Any doubt for muscle injury, check CK and LDH and urine for myoglobin, chest X-ray and ECG. ECG for cases with electrical burn or some sort of chemical burn that may cause cardiac arrhythmia, you always do it. Easily missed is putting an NG tube for decompression and at the same time start stress ulcer prophylaxis. So we complete with a secondary survey. So for the burn wound management, how do we address the burn wound? So if your patient presents to you within the first 3 hours of their injury and they have not had any first aid, you can consider performing first aid for them, running the burn wound under tap water. It helps to stop the burning process. However, do not use ice or ice water as they cause vasoconstriction and that may deepen the burn wound. At the same time, keep the patient warm, especially in pediatric cases. Then we start with some simple dressings like non-adherent chili or wet gauze, and we elevate the affected limb above the head level to reduce the tissue edema and improve the tissue perfusion. Remember to remove any watches and jewelries. So this is the referral guidelines to burn center. I think you should also know this as well because that helps you to triage cases in future. If the area is large, more than 10%, if it involves some special regions like face, hands, feet, genitalia, perineum, or across the joints, then you refer those patients. If the burn wound is like full thickness burn, special mechanisms like electrical burns, chemical burn, obviously inhalation injury. If the patient got very complex comorbidities or concomitant trauma, then you will have to refer them to a burn center for further care. Then we'll move on to talk some special mechanisms. Sure. Photocopy. Tiếp theo gì không thêm? Xem á. Hổ,唔該，拜拜。好，唔該，拜拜。So chemical burn. So chemical could be classified into either acid or alkaline, and they have different mechanism to cause the burn damage. For acid, they cause coagulation necrosis, and for alkaline, they cause liquefaction necrosis. So alkaline is more damaging than acid because they penetrate deeper. And for acid, when a coagulum is formed, usually the penetration stopped. Exception is hydrofluoric acid. It gives liquefaction necrosis, and the injury severity depends on the pH, the concentration, the length of the contact time, and the TBSA being involved. So for a chemical burn, is to irrigate with normal saline and at the same time prevent the contaminated irrigation solution from running onto the unaffected skin. We'll have to remove all the contaminated clothing and shave the hair if the scalp is being involved. Deflurane is an agent, chelating agent that helps to neutralize the chemical. I think they are available in some A&E or in the lab that handle these dangerous chemicals. They could be applied over the eyes of the skin. For hydrofluoric acid, this one causes liquefaction necrosis. The small amount of very concentrated hydrofluoric acid could cause a fatal burn injury. Because the fluoride ion present in this chemical will relate with the cations inside your body, such as calcium and magnesium, and producing hypocalcemia or hypomagnesemia, causing cardiac arrhythmia. And the fluoride ion could be directly toxic to the myocardial cell as well. So for these patients, you've got to check their calcium ion, magnesium ion, put them on cardiac monitor, and find ICU if you're in doubt. And there are some first aid kits that contains calcium gluconate in a gel form or eye wash, helping to remove the fluoride ion. If in severe cases, we can consider a subcutaneous injection of the calcium gluconate. Remove the nail plate because that is a very good reservoir for the chemicals to hide in. Cardiac monitor for arrhythmia, check blood electrolytes urgency and repeat at interval, and ICU support. And then other entity is electrical burn. It could be classified as high voltage or low voltage. Always search for the entry and exit sites for occurrence, and the anatomical location of these sites could help to determine the current pathway inside the body. So these cause very deep tissue damage, and patients could be prone to rhabdomyolysis as well as compartment syndrome. So in those cases, check for the CK, LDH, do the ECG and check cardiac enzyme, and find ICU if necessary. NAI, I think, is covered in pediatric modules, so I'm not going to repeat. So for burn, up to here, any problem? If no, then we'll talk something about the pathophysiology of burn injury. So this diagram shows the Jackson's burn model. It shows that for a burn wound is a very heterogeneous wound. It composed of three different zones, namely the zone of coagulation, the innermost area, where the tissue got no viability because all the vessels that are famosed. And the peripheral part is the zone of hyperemia. It's a zone of vasodilatation with increased blood flow. And in the middle is the zone of stasis. It is where we try to salvage with appropriate first aid and resuscitation. So when the burn area is more than 25%, the zone of hyperemia, that is the vasodilatation part, could involve the whole body. It's part of the general response of the burn, and it involves a release of inflammatory mediators causing a vasodilatations with very leaky capillary. So the intravascular fluid could escape to the extravascular compartment, taking together the albumin and cause the shock. And this extravascular fluid accumulation will cause edema and cause airway obstruction, as well as compartment syndrome in limbs and abdomen. So the zone of stasis, they could either progress or recover, and they will declare itself in 3 to 5 days after the initial injury. And the progression could be minimized by appropriate first aid, limb elevation, and proper wound care to prevent the infection. So coagulation is where surgical debridement is healed with no potential for spontaneous recovery. So this diagram showed how the intravascular volume is leaked to the extravascular space. Because the capillary wall becoming very leaky, usually the albumin is contained in the intravascular compartment. Now they escape to the extravascular compartment, drawing together the fluid. And it causes von depletion, that's a hypovolemic shock, and posing early threats to the acute burn cases. So systemic response, I think I will probably skip this part. Yes, so for burn, this part, any questions? If not, then we'll move on to next topic.
Dr. Tam, I wonder what kind of chemical would need ECG or cardiac monitoring for chemical burns?
I mentioned it in the previous slide,
Except
hydrofluoric acid.
only HF needs.
I think for your level, you just need to know hydrofluoric acid.
Okay, thank you.
Any other questions about burn? So how to calculate the resuscitation fluid, the assessment of the burn in terms of the depth and the area. So these are important things you've got to know, and they are very likely to be asked in your examination. So if no further questions, then we'll move on to other topics. So skin cancers. I think it will appear in your final MB, most likely. There are various kinds of skin cancer. I'm not going to cover all of them. But apart from skin cancers, I think you still need to know some common benign lesions that could appear in your OSCE station as the differential diagnosis for your skin cancer cases. Because they do appear in some stations like neurofibroma or some seborrheic keratosis, lipoma, sebaceous cyst, they could still appear. And the only answer, the skin cancer is not the only answer in your examination. So sometimes I see people are unable to give differentials for of benign causes, and that could also make you fail the exam. So be familiar with some common benign skin lesions as well. So these are some commonly named or examined entities of skin cancers: basal cell carcinoma, squamous cell carcinoma, melanoma, DFSP, angiosarcoma. So how do we tell from history and physical examination whether they are benign thing or abnormal thing? So in history taking, you start with the duration and onset of that lesion. If the onset is recent with a very rapidly enlarging lesion, then you might as well consider them to be malignant unless proven otherwise. Any spontaneous bleeding, any risk factors of your patient in his background history, like or excessive exposure to UV, like some childhood arsenic poisoning. Then in physical examination, you check for your ABCDE, the asymmetry, the border, the color, the diameter, and any evolution of the lesion. So in the OSCE station, you must be able to elicit the history in a very short questions, a few questions. You've got to complete your history taking. You cannot waste a lot of time to ask about irrelevant history. So because they are bound to be short cases. So then basal cell carcinoma, this is a very classical appearance of it. It could, they are most likely pigmented or pink or skin-colored lesion. They have an irregular border. They could be nodular, but sometimes they could be flat, a patch of discoloration. They had a they have a pearly rhodal arch with surrounding telangiectasia and a central ulcer. Most of them are slow growing, so the lesion could be there for a few years even, and they rarely metastasize to neighboring lymph nodes. So for squamous cell carcinoma, they could be a nodule or they could be a scaly patch. They have a very poorly defined border. There could be a pre-existing ulcer or scar, and what's that called? In case a squamous cell carcinoma arising from a pre-existing ulcer, what's that called? Anyone got the answer? I think it's a very simple question. You should be able to give the answer. Start with M.
Marginal ulcer.
Okay, so it could be some itchiness or pain accompanying, and these squamous cell carcinomas could metastasize to lymph node. That's why in your physical examination, if you think it is a squamous cell carcinoma, please also at least say you want to do a regional lymph node examination. So the risk factors for non-melanoma skin cancer. So these two are grouped as non-melanoma skin cancer. So Fitzpatrick skin type 1 and 2, that means those are white skin, age, chronic and excessive UV exposure, some carcinogens like arsenic, immunosuppression, like patients with organ transplant being on immunosuppressants for a long period of time, some genetic disorders like xeroderma pigmentosum, albinism. So other risk factors for squamous cell carcinoma, HPV infection, some inflammation like Magdalene ulcers, radiotherapy history, actinic keratosis, Bowen's disease, leukoplakia, and urothroplakia. For BCC, Golden syndrome, and sebaceous nevus. So for basal cell carcinoma, so what are the poor prognostic factors for these lesions? If the size is larger than 2 cm, if the site is over central face, especially ear, eye, lip, and nose, if the histology subtypes fall into this infiltrative or basal squamous, if the final pathology reviewed show there is perineural or perivascular permeation, then these are the poor prognostic factors for basal cell carcinoma, namely that they could recur more likely. If the patient is on long-term immunosuppression, if it is a recurrent lesion already, then it also poses a poor prognostic effect on your patient. So how about squamous cell carcinoma? If the lesion is arising from a Magdalene ulcer, a Bowen's, if it is over in non-sun exposed areas, then the prognosis is worse. Of course, the diameter, if it's more than 2 cm, the rate of having distal metastasis is like 1/3, and the recurrence rate is like 1/6. And the depth of invasion, if it's thicker than 4 millimeter, then the metastasis rate is close to 50%. So in these cases, after you've completed the excision, you still have to arrange some kind of examination for the patient, like ultrasound, to look for any occult lymph node metastases. So histology, of course, poorly differentiated with perineural or lymphovascular permeation are worse. So of course, like BCC, long-term immunosuppression and recurrence, the prognosis is worse. So for treatment, so for the margin of excision, so there are different guidelines, but in daily practice, for well-defined lesion less than 2 cm, we usually use 3 mm radial margin for excision. So of course, 4 mm margin, they'll give you a better clearance. However, in some aesthetically important area, that 1 millimeter does matter. So we employ this 3 millimeter radial margin for excision. However, for more poorly differentiated BCC, like those we call hemophilia-form BCC, then the excision margin could be different. Like for 3 millimeter, we only achieved 66% clearance. So for 5 millimeter, 82%. Then we have to judge case by case for the margin we use. But as a rule of thumb, we'll use 3 millimeter unless the lesion is particularly ill-defined or the patient has for SCC. So for high-risk lesions like those ill-defined more than 2 cm with extension to subcutaneous tissue over the eyelid, ear, scalp, and nose, then they are classified as high risk. And those high-risk lesions, we might consider 6 mm excision margin. For lesion other than those, we may use 4 millimeter. But of course, there is always an argument. So conveniently, you can give the answer 4 millimeter. But if they are over the limbs, those aesthetically less important area, and if the lesion is really very sizable and ill-defined, you may as well argue for 6 millimeter. So cannot give you a concrete answer for your OSCE station. It really depends on the case that you encounter. So melanoma, the risk factors, apart from those sunburn, there are other risk factors like a dysplastic nevus, a congenital nevus, a melanoma in situ or lentigo malignant history, a typical mole syndrome, and immunosuppression. So you've got to ask for your patient if you're suspecting melanoma. You've got to check if they present with these background risk factors. So there are different subtypes of melanoma, namely acrolentigenous, superficial spreading, nodular, lentigo malignant, desmoplastic, and amelanotic. So what do we classify as in-transit metastasis or satellite lesion? I think for this one, you might need to know a bit. For in-transit lesion, is any skin or subcutaneous metastasis that's more than 2 cm from the primary lesion, but not beyond the regional nodal basin. So that we call as in-transit. So more than 2 cm. For satellite lesion, are any skin or subcutaneous metastasis that is within 2 millimeter from the primary lesion and not beyond the regional nodal basin. So that's why in your physical examination, apart from describing your ABCDE, the site and the size of the lesion, you may also need to describe if there is any in-transit or satellite lesions, because that may signify the higher risk for the primary lesion to go into the nodal basin as well. And for the role of sentinel lymph node biopsy as well as the surgical margin, this diagram summarizes it. For those lesion that is what we call as an intermediate thickness, we will offer for sentinel lymph node biopsy. And if that sentinel lymph node biopsy came back to be positive, then we will offer the patient for a regional lymph node dissection. And this, I think this is also the update guidelines. The breast lobe thickness and the presence of ulceration will give the T staging, and then the N staging depends on the node status. So I think for skin cancer, most likely they will appear in your short case OSCE examination. You must be able to describe their clinical features. How do you arrive in a diagnosis? When will you use incisional biopsy? When will you use excisional biopsy? Then your surgical margin for those cases. For BCC, conveniency as 3 millimeter. For squamous cell carcinoma is 4 millimeter. For melanoma, For melanoma, do we use incisional biopsy or excisional biopsy? Well, I think it's also a simple question that you should be able to answer. And the reason why we use which one. Can someone give the answer? For lesion, you're suspecting it to be melanoma. Do you do incisional biopsy or excisional biopsy? And why? If this question cannot be answered, we cannot move on to the next section because that means that you're not familiar with skin cancer management yet. Hello? Anyone want to try?
I think excisional biopsy should be done, but I'm not sure the reason. Is it because like you want to know the thickness of the lesion?
Okay, so any other answer from the floor? So anyone will propose for excisional biopsy? So that means all of you will go for incisional biopsy. Or you don't know? Okay, seriously, if we cannot get this question answered, we will not move on to next topic.
I think we need to do excisional because the depth of the lesion will provide diagnostic purpose.
What kind of diagnostic purpose you're talking about? I'll say you're correct that we will do excisional biopsy, but you need to know why.
Because it will determine the surgical margin. Is that so? The thickness or the depth of the.
Okay, so this slide already gives you the answer. So for the depth of the tumor and the recommended excision margin, the depth of the tumor will govern your radial margin of excision and whether you proceed with sentinel lymph node biopsy. Can everyone appreciate over this part? It's already written there. So why the depth of the tumor could only be obtained accurately from an excisional biopsy, but not an incisional biopsy? So from the incisional biopsy, if you ask the pathologist, they could still give you the depth of the tumor, how thick it is. So why we cannot use the answer from our incisional biopsy to govern our excision margin?
Because in incisional biopsy, only portion of the tumor is taken out, whereas excisional biopsy, the whole tumor is taken out.
Yes, I know. But then what makes it inappropriate to give the margin guidance?
Is it because the depth of the mass can differ from, it's not constant for the whole tumor?
Because that we would call it as a sampling error. So we could sample somewhere that is thinner for the tumor and give a wrong or misleading tumor depth, and then it will give rise to an inappropriate excision margin. Say like if you sample the tumor and the depth to be less than 1 millimeter, but then if you do the excisional biopsy, eventually found out that the tumor depth is more than 1 millimeter, then your excision margin, if you follow that less than 1 millimeter, then it will be too narrow. It will not be wide enough. And for that reason, we always have to proceed with an excisional biopsy. And I think this is very basic knowledge for melanoma, that excisional biopsy is the only way to give the accurate recommended excision margin. So if you've ever come to our clinic or listen to any of our lecture given previously, you must be able to record this bit. So we do not ask for very complex, like the percentage of survival or prognosis or those target therapy for melanoma, but at least you need to know the excision margin and the relationship between breast cell thickness and margin and sentinel lymph node. Okay. So any questions with the part about skin cancers? No, then we'll move on to the next topic. So we'll go back to some basic stuffs about plastic surgery. We'll talk about wound healing and scar, abnormal scar, as well as some different kind of dressing, as well as the reconstruction ladder. And this will be the last part of the tutorial. So maybe we'll skip this very basic kind of thing. So for wound healing, there are 4 phases of wound healing. So first is the hemostasis, then followed by inflammation, proliferation, and remodeling. And the process of wound healing could actually last for over a year. So in inflammation, hemostasis is the immediate phase of wound healing. It's the event that happened is vasoconstriction, and the platelet plaque is formed to stop the bleeding. Then in 2 to 3 days time, inflammation will set in. It involves vasodilatation, so the wound will look erythematous, and the predominant cell type is neutrophils and monocytes. Then after the inflammation phase starts to subside, then the proliferation phase will set in, but the two will overlap for a while. And proliferation phase will start on the 2nd or 3rd day and last for 2 to 4 weeks. And the cell type that is involved is fibroblast and myofibroblast. And these cells will lay down collagen to remodel the wound. Then the remodeling phase will begin 2 to 4 weeks after the injury, and it can last over a year. And in this phase, the type So the type 3 collagen will be replaced by type 1 collagen to reach a collagen homeostasis. But even with a very smooth and undisturbed wound healing, the wound strength cannot go back to 100% as its pre-injury status. It will reach 80% as its maximal strength. And 50, that's why the scar eventually strength will not be the same as your original skin. So if that curve appears to reach 100%, that's definitely wrong. So the curve is like that. That will grow up, and then eventually it will reach only 80%. So there are some factors that could affect the wound healing. So some systemic factors, congenital ones, including disease that affect collagen synthesis. An example is the epidermolysis bullosa. Some acquired systemic factors like malnutrition, some vitamin or trace element deficiency, some medications like cytotoxics and steroids, endocrine disorders like DM or hypothyroidism, advanced age, smoking as a cause of vasoconstriction by nicotine, and carbon monoxide will reduce the oxygen carrying capacity, and some cyanide poisons will affect the intracellular oxidative metabolism. So apart from systemic factors, there are some local factors affecting wound healing as well, namely infection, radiation, the blood supply, like peripheral vascular diseases, trauma, neural supply. So when a wound is healed, a scar is formed, but there are some abnormal scars, the two most common one being hypertrophic scars and keloid scars. So this is a table summarizing the difference between an hypertrophic scar and a keloid scar. So for hypertrophic scar, they develop right after the wound is healed. However, for a keloid scar, there could be a few months of latency period after the initial trauma. Hypertrophic scar usually improve with time, what we call it as a scar maturation, but for keloid scar, they will never regress. And the margin of an hypertrophic scar will limit to the initial injury or surgery, while for keloid, they will extend beyond the wound margin. And for the collagen component, for hypertrophic scar, they are well-organized type 3 collagen bundle. And for keloid scar, they are poorly organized type 1 and 3 collagen. And for hypertrophic scar, it contains myofibroblast and causes the contraction of the scar. Why? 係啊，咩我？咩個 coverage concern 啊？我得而家過嚟啊！係啊，拜拜。個 concern 啊？我聽唔落喎。而家入房喎。佢會快。Okay, so yes, for keloid scars, there is no myofibroblast and no scar contracture will happen. For the common sites for keloid scar, the chest wall, shoulder, and ear loop, patients with darker skin are more prone, and there could be a positive family history. So this could appear in your MCQ questions concerning the difference between hypertrophic and keloid scars. So for scar management, we'll start with some simple measures like silicone gel sheets. We can put a patient on pressure garment, intralesional steroid injection. There are some available cryotherapy that are performed intralesionally to manage the scar, but is not conventionally available in HA setting. We can do laser. And the last resort is scar excision with radiotherapy, especially for very disturbing keloid scars. So this is a table showing how do we assess the scar activity. On the right-hand side is the Vancouver Scar Scale, is a more old-fashioned kind of scar assessment form. There are 4 components. First one is the vascularity. Second is the pigmentation. Third is the palpability. That means whether it is soft or it is very firm. And fourth is the height. That means the thickness of the scar. So the vascularity is describing the color of it, actually. So with a higher mark, that means the scar is more active, and it could be more symptomatic. And we will have to intervene with the measures that were described before. And on the left-hand side is the POSAS chart or questionnaire, I will say. It consists of two modules. First one done by the observer, that's the clinician or other occupational therapist that manage the scar. And the second one is by the patient. So it describes the subjective feeling, whether it is painful or itchy, and it can from the patient's point of view. Okay, then the next topic we'll talk about is the reconstruction letter. So for plastic surgery, namely what we're doing is to cover any kind of defect over the body. So we will follow this reconstruction ladder. First, being the lowest on the ladder is healing with secondary intention, that is dressing. Now move on, we can do direct wound closure, skin grafting, tissue expansion, local tissue transfer, distant tissue transfer, or free tissue transfer. The purpose of reconstruction is to restore the form. That means the appearance, the aesthetic. Most desirably is the aesthetic appearance, and also function from a congenital or acquired pathology. We tend to replace the lost tissue with something that is alike. That means if there is a bone defect, then we'll replace it with bone. If there is a skin defect, then we'll try to replace it with skin. So dressing, I'm not going to details into dressing, but there are various kinds of dressing that we use, and I think you need to know the property of each and the application of each. So what kind of wound should we use for which kind of dressing? So for low adherent dressings like chili, then they are like gnat. There were some holes in between to allow the exudate to pass out. Hydrogel, they donate water to the wound surface, so they're good for some very dry wound or wounds that you want to maintain a moist environment. So alginate, they absorb the moisture, so they're good for wounds being very exudative. Hydrocolloid, synthetic foam, yes. So negative pressure wound therapy is a special kind of wound dressing that is quite readily available. It is involved a foam being put into the wound cavity and then connected to a suction tubing. So it helps the wound to heal by a direct suction force to pull the wound inward, and it increases the angiogenesis and granulation tissue formation. For acute wounds and 50 to 70 mmHg for chronic wounds. It could also be applied over a skin graft to improve the take of it. So this is a diagram showing how it is like at the bedside. Despite that it's being so useful, there are a few contraindications for applying a negative pressure wound therapy. First one is an untreated malignancy within the wound, because by promoting angiogenesis, it will promote growth of the tumor. Any untreated osteomyelitis, unexplored fistula, exposed viscera of major vessels, necrotic tissue or eschar. And we do not use it on ischemic wounds as it may increase the zone of necrosis. Then moving on, the reconstruction ladder is something what we call a tissue expansion. So on the diagram showing various kind of tissue expanders, it is a medical device being inserted into a subcutaneous layer, and then we will do regular injection to inflate it. Yeah, we'll go. Ready? 你 ready？ 咁你幫我同老細講，我教完書就會入嚟，應該唔會太耐。我放覆先，覆緊。 PRS 係咩事？係 ready？唔係係咪真係 ready 啊？個 case？哦，好好得，拜拜。等你嚟省心講乜嘢？好怪。So it will be regularly there will be regular saline injection through the injection port to expand this device, and that will cause a phenomenon what we call as a stress realization. So it's time dependent. So it may take months to complete the whole process. And through this process, the epidermis will be thickened and the dermis will be thinned. The skin appendages, namely the hair follicles of the sweat glands, they will be separated, and there will be an increase in vascularity. So eventually, the skin will increase in its surface area. So it could be used to rehydrate after excision of some skin lesion or unwanted scar. So this tissue expander comes in various shape and size. They could have integrated or remote injection port. So the procedure is performed as a stage operation, with the first stage being a tissue expander insertion in the subcutaneous layer, then weekly inflation. After the skin is being expanded, at the second stage, the tissue expander is removed and the skin is rehydrated. The advantage of using tissue expansion is that it gives the best color and texture match because it's applying the neighboring skin to cover the defect. The skin expanded retains a sensation, and there is no extra dermocyte and its related mobility. However, it's contraindicated over irradiated skin, immature scar, area with infection, and skin grafted sites. There could be some complications arise, like hematoma infection. The tissue expander could be exposed if the skin is breached, and it could cause extrusion. There could be neuropraxia if main sensory nerve is being tracked by the tissue expander. And there could be some pressure effect over the surrounding tissue, causing some temporary deformation, especially the bone, like the skull and the rib. And there could be accidental perforation when you're doing the injection and flipping of the injection port as well. Then moving on, skin graft. So a graft is anything that without its own blood supply being retained. So partial thickness and full thickness. The difference is that for partial thickness, there's a variable amount of dermis, and for full thickness, we take the whole layer of dermis. Donor site for PTSG is thighs and back. For full thickness, because we have to primarily suture up the donor site wound, they're most taken from the flexural areas, the pre and post auricular area, or the suprainfraclavicular area. So partial thickness skin graft got secondary contracture due to myofibroblast in the wound healing process after a graft is being taken. And for full thickness skin graft, the primary contraction is due to the elastin and dermis after the graft is being harvested. So for skin graft, for it to heal, there are also 4 phases. First one is the adherence phase, where fibrin bonds are formed to attach the skin graft to the wound bed. Then in the first 2 to 4 days, there will be serum inhibition. So the next phase will be revascularization. There is vessel ingrowth into the skin graft. And then the last phase is being the remodeling phase. Well, this is a diagram showing the harvesting of a skin graft. This machine is called a dermatome. So it could harvest the skin from the thigh and the various donor size, PTSG, I mean. So it carries different guards to harvest skin graft of different width. And the dial could adjust the thickness of the skin graft being harvested. And then we can use a measure, that's the lower right diagram, to measure the skin to increase its surface area as well as giving host for the underlying seroma to pass out. So reasons for skin grafts to fail is hematoma formation, seroma formation, shearing cause it to dislodge from the recipient wound, an infection, notoriously the group A beta hemolytic streptococcus that reproduce streptokinase and hyaluronidase to cause the skin graft unable to adhere to the wound bed. Inappropriate wound bed, like those avascular wound bed or irradiated wound bed, technical error, if you put the graft upside down, then the graft will never heal. So dermal substitute. The dermal substitute is something artificially made to replace the dermis. So it's a bilaminar dermal template composed of a thin outer top layer of silicone sheet to resemble the epidermis, and thinner inner layer of bovine collagen and shark glycosaminoglycan, behaving like the extracellular matrix that helps to organize the fibroblasts and collagen to form a new dermis. And the time for it to revascularize is around 3 weeks. So it's a stage operation coupled with a thin SSG. For dermal substitute, it gives better contouring because it replaces the thickness of the dermis, and there is less secondary contracture. That means the scalp will be better. It carries the less donor site morbidity. However, it has a risk of infection for this avascular material to start with. So for flaps are classified when it retains its own blood supply. So it could be the classification could depend on its contiguity, whether it's a local flap, a regional flap, or a distant flap, or by its composition, whether it carries a skin as a cutaneous flap, carries fascia and skin as a fasciocutaneous flap, myocutaneous, muscle only, osteocutaneous flaps. So geometry of local flaps, I don't think you need to know about much about local flaps. So yes, so for microsurgery. Microsurgery is what we use. When we use free flaps that involve joining up of the flaps vessel with the recipient vessel. So for microsurgery, this is what happened after the two vessels are being joined. So there will be a pseudo-intima formation at the anastomosis within 5 days, and the new endothelium will cover the anastomosis within 1 to 2 weeks. So the factors that affect the success of the anastomosis, that means joining up of the two vessels, of course, the rough vessel dissection, desiccation of the vessels, diaphragmy, prolonged vasospasm, the surgical technique, the use of the too large needle, repeated needle stab, unequal bites, loose sutures. I think that may be a bit beyond your level as medical students. But for this one, flap monitor. So even though you do not know how to do a free flap surgery or the technical pros of free flap surgery, as an intern in exterior, I think you should be able to recognize whether a flap is failing. So there are a few parameters we monitor for a flap. So namely the temperature, the color, the target, the capillary field, and needle prick. Of course, we can use Doppler signal to ascertain. So this is a diagram from online. So can anyone tell me what's wrong with this patient? So this patient had a breast reconstruction. She has a flap over her right breast. But can anyone tell me, is it normal appearance or is it abnormal? And if it is abnormal, what's going on? And how are you going to manage this problem? Have you ever seen any flap surgery or patients with flap surgery in the ward? Hello? Hello?
I don't think we have.
Sorry, I cannot hear you.
I don't think we've seen any.
So, but this is something that could be asked in examination. So, flap monitoring or what is a fouling flap. So do you think this is normal or abnormal, the color of the flap here? I would say in your examination, you may not, you may as well see something that you've never seen in your past 5 years of medical MB CHP education. So you still have to find a way systematically try to answer the questions. So what is this?
This shows a breast reconstruction flap with purple discoloration, looking cyanotic with a black margin. So I think it's devitalized flap failure.
So when we classify a flap failure, we will want to know whether it is an arterial inflow problem or if it is a venous outflow problem. So for arterial inflow problem, meaning that there is inadequate blood flowing into the flap to support it. While for venous outflow problems, meaning that the venous drainage is inadequate, so the flap got congested. So which one do you think it is? It is a arterial problem or it is a venous problem?
I think it's a venous problem.
So for venous problem, you're correct. So this is most likely a venous problem. Why do you think it is a venous problem?
Firstly, it looks congested, and it looks also slightly edematous, and also venous thromboembolism is a more common cause for flap failure.
That's very good. So you're able to appreciate that the color is purplish, is a very typical appearance for a congestive flap. For an arterial problem, the flap usually look very pale with like no blood flowing. That's why there's no capillary review. So how about for a congestive flap? What do you expect for the capillary review?
I think the capillary review will be delayed.
So for delayed, it's usually due to there's no blood. That's why it's delayed. But if it's for a venous problem, there's a lot of blood pooling inside the flap. Will it be delayed or will it be something else?
I think it would be brisk.
Yes, it will be brisk. And edematous is a very good term. We'll call it as a very turgid flap because the flap is very engorged with a lot of blood pooling inside. But you can see those like if you look closely that not look closely. If you're able to palpate it, you will feel it is very firm. It's very turgid. That's what we call. And the temperature of it could still be present because there's still some blood inside. But for arterial insufficiency, the flap is usually very cold and it's very flaccid. and the capillary refill will be very sluggish, more than 2 seconds, or even absent. So first thing you've got to know is whether it's an arterial problem or it is a venous problem. So for venous problem, the next thing, how are you going to manage? So it's very congested. It's a very, it's a failing flap. It's not yet fouled. So how are you going to do to at least do something to temporize and buy more time for the definitive treatment for this failing flap?
I think we can try heparin infusion.
Heparin infusion? Okay, so come back to something very basic. So if the venous outflow is blocked, so we will have to check for several things. So I think this is very important when in future you are working as a surgical intern. So for every this kind of patient that goes wrong, check the drain output. If the drain is blocked, then obviously something will go wrong, because the drain is there because it serves its purpose to drain the unwanted excessive blood or seroma out. So when a drain is blocked, it would compress on something. So that may cause the compression of the venous outflow and cause this venous congestion. So first check if any blocked drain, and then palpate for the surgical site for any developing hematoma. I think for this lady, her reconstructed breast is significantly larger than the contralateral one. So I will have a good guess that there might be a developing hematoma. And in that case, you might as well want to release some suture at the bedside to release the pressure and tension surrounding the flap. So, so you must be prepared for something to appear in examination that you might never see it before in your study, because the exam is to test whether you're ready to be a doctor, an intern that treats real patients. So you apply your knowledge and make some very systematic deduction of what is happening and give your answer. So I will not be surprised if this kind of scenario happened in your examination. So be prepared to think of a way how to answer systematically and logically if you come across something that you've never encountered in your work, okay? So I guess this more or less sum up the main things in plastic surgery. Just now you mentioned something about streptokinase or heparin infusion. Yes, these agents are used to lyse the clot if there's any, causing the anastomosis to block. But those are more advanced things. So at the level, at least you need to know what could be done before the patient moves into operation theater. And the last bit of our module will be on facial trauma. But I think Dr. Leung had gave lectures on facial trauma already when you are rotating to plastic. So unless some of you have never had the facial trauma tutorial, otherwise I'm not going to cover it, because there's another very comprehensive topic. Any one of you had never had the tutorial from Dr. Leung about facial trauma?
I think some of us missed that because of the recent COVID problem.
No, the tutorial has always been happening. That's an e-lecture online.
Oh, it's online. Okay, sorry.
I mean that it's a Zoom format. It's never stopped. Every week we are still doing the teaching. If you miss it, it's either you did not log in or something else.
I'm not sure, but I only remember like there was one burn tutorial before that was shut down, and afterwards for the entire week of the other half week of class, I don't recall any such.
Okay, so
some of us missed it because of Chinese New Year that week.
Oh, all right. So, So I'll just, I need to reply for a few calls. So a couple of minutes break, then I will just go through very roughly on the facial trauma because I have an EOT happening right now. So 5 minutes break first. Okay, so maxillofacial trauma. So, apart from facial fractures, I like to name it as a maxillofacial trauma because apart from the bone, there could also be soft tissue trauma. It could be blunt or penetrating, soft tissue or bone involvement. Very commonly, there will be concurrent brain injury, cervical spine injury, or eye injury. So the principle of it is really like ATLS. Manage the airway, breathing, and circulation is the first thing to be done. So facial bones. So this is the different bones that forms your face. So frontal bone, zygoma, your maxilla, your mandible. There are smaller ones like the nasal bone and lacrimal bone. So anyway, this may not be most important. So airway, I do not repeat, but you need to know they could happen because of the direct trauma or because of the bleeding. If that happens in your facial trauma patient, the bleeding could be very profound because the mucosa, when they bleed, is very profuse. So you might have to consider protecting the airway. And any foreign body, any dislodged teeth or bone fragment, provide C-spine control because as high as 10 to 15% of patients got the head injury will have the C-spine injury as well. So intubation by airway expert and standby surgical airway in the form of tracheostomy or tracheostomy. So circulation, the bleeding could be tremendous. So what you can do is to apply direct pressure. Otherwise, you could do nose packing if you suspect that bleeding is from the nasal cavity. There are some Merosil readily available in A&E. You can just put it inside the nose. Of course, you have to rule out any scalp-based fracture. So sometimes you may have to consider EOT for bleeding control, especially those open fracture. You may have to hold it temporarily with IMF for the mandible to control the bleeding. And embolization by IR rarely done, but sometimes happen. So history and physical examination, if your patient is stable enough to be obtained for the history and physical examination. So inspection, look for any asymmetry of the two sides of the face, like flattening of the cheek, down slanting canthus, tally canthus. That means the two canthus are being very apart from each other. Chin deviation, any swelling or bruising to suggest for underlying fracture, open wounds, any ear hematoma and septal hematoma, and palpate for any bony tenderness and stepping. So septal hematoma. This is the clinical picture showing a septal hematoma, and on the right-hand side is what it is like anatomically. So the hematoma developed under the perichondrium will press on the nasal septum and cause this piece of cartilage to necrose. If it is untreated, the pressure necrosis will cause a resultant deformity of the nose, a nose deformity. So it is a surgical urgency to evacuate this septal hematoma, just incise on the perichondrium and then wash out the hematoma. But it has to be done in a timely manner. So ear hematoma. So also a hematoma developed under the perichondrium over the ear cartilage. And also urgent decompression is needed, coupled with some pressure dressing being tied on the ear to prevent its recurrence. Because if it's left untreated, it will also cause an ear deformity, what we call as a claudifour ear deformity. So specific examination. So do it systematically. I will try to perform it from top to bottom. So check with the extraocular movement, any ophthalmoplegia. If the patient try to move their eyes, are they painful? Are they seeing any double vision? Check for the infraorbital nerve. Also check the visual acuity and pupillary reflex. Trismus is any painful and limited jaw opening. Malocclusion, namely the clenching of the teeth. When you ask the patient to clench their teeth, they feel that their teeth are not in the correct position. So they could be subclassified as cross-bite, open bite. And check for any ventral nerve numbness, and eventually check for the facial nerve function. So extraocular movement, double vision is like they seeing one object but with dual image. And on the right hand side, you see when the patient is instructed to look up, the right eye move up, but the left eye do not. That means there is entrapment of the extraocular muscle causing ophthalmoplegia, and they will see diplopia, and they may complain of pain when they're trying to look up as well. So my conclusion, this is a very good illustration. You can see the lower jaw teeth alignment are completely disrupted. There's a mandible fracture for certain. So when you ask this patient to clench their teeth, they will feel that obviously the tooth are not in their original position. So for specific tests, skull-base fracture, there will be CSF rhinorrhea. So we can do a halo test, seeing two rings with the center being the blood and the outer one being the CSF, or you can do beta-2 transferrin. But beta-2 transferrin result will not be readily available. So really it's with any CSF rhinorrhea, you can check with this halo test, or you can confirm with a CT scan, because the beta-2 transferrin will be a very delayed result. So imaging nowadays is CT as the gold standard. This is the 3D reconstructed view. OPG is also a very good tool to see the side of the mandible, like the condyle, the ramus. But they're better seeing the midline structures like the symphysis or the parasymphysis. So soft tissue injury, simple lacerations that are repaired within 24 hours at bedside. The wound should be cleaned up from any debris or broken glass pieces to prevent future infection, or the debris over the wound will cause traumatic tattoo. So give systemic antibiotic if you think the wound is heavily contaminated, like they hit on the ground or rub on the ground with a very dirty wound. For wound with tissue loss, we can temporarily dress it to keep it moist and clean, and then we can try to go for a definitive repair by skin graft or sometimes local flap when the wound is in a better condition. So remove foreign body, dirt, necrotic area, layered tension-free closure. Good apposition of the anatomical landmark, like over the lip, you have to match the vermilion border, the brow, the lid margin, because as tiny as 1 millimeter difference are noticeable. So tissue loss, skin graft, or local flap. So parotid duct. So if there is also good. So what's the surface anatomy for the parotid duct? What is the surface anatomy for the parotid duct? So if you suspect a parotid duct injury, that means the injury violated is a surface anatomical landmark. So what is the surface anatomy for the parotid duct? Can somebody answer? This is a preclinical year question. So the surface anatomy of the parotid duct.
I think it opens opposite upper second molar.
That's the parotid duct opening. You're correct, but that's the parotid duct opening. How about the duct, the course of the duct? The duct.
1 finger breadth below the zygomatic arch.
Any different answer?
It's the middle third of the line between the tragus and the angle between the nose and the mouth.
Between the nose and the mouth. Okay, very close, but not exactly. So it's an imaginary line from the tragus to the upper mid lip. So it runs along with the buccal branch of the facial nerve. So the duct opening is opposite to the second upper molar teeth. So if any of the injury, particularly those through and through injury, that cut along this line, then you might have to consider this parotid duct as well as the buccal branch being injured. And in those cases, you have to repair it or ligate it. So it has to be done under GA. So this is a intro diagram showing the cannulation of the parotid duct. And how do we identify a duct injury? So we'll cannulate the parotid duct and then inject some other dye, or sometimes we can use H2O2 to see if there is any leakage at the wound edge. So if there is some leak, that means the duct is transected. Then you have to either identify the other cut end of the duct and then repair it. And if that is not identifiable, then you've got to ligate the duct. Otherwise, there will be persistent saliva leak causing a striatal seal formation. Okay, so buccal branch repair is optional because the buccal branch, the innervation of it, can be replaced by the other branch of the facial nerve. But if you are able to identify the two cut end, also repair it. So facial nerve primary repair stumps are identifiable. So the zone of injury is medial to the lateral canvas. Those are usually not repairable because the nerve is too tiny. So if it's medial to the lateral canvas, then usually we will not try to repair it. Otherwise, if it is lateral to the lateral canvas, we'll try to find two cut ends and then repair it. So facial fracture, we follow the AO principle in the ORIF. So the detailed reference will be on the web, but I'm not going to go into the fine details of it. Frontal sinus fracture is uncommon, but they could be classified into anterior and posterior table, whether it involves the frontal nasal duct and any concomitant brain injury. So this is a diagram showing both the frontal, the anterior and posterior table being involved. So we will have to find it with surgery. You can see it there is pneumocephaly. It could be conservatively managed with just the anterior table undisplaced. If it's posterior table involvement, then we might need to see the pros and cons of repairing it. So the approach is pericoronal incision, and then fix the bone fragments. Sinus obliteration is to prevent the mucocele formation. And this is a diagram summarizing it, but I don't think you need to know much about frontal sinus fracture. Just some more common things like orbital fracture. They could be either blow in or blow out. Blow out is more common. So when there's change in orbital volume due to the orbital fracture, it could cause endothymos or exophthalmos. So for blow-out fracture, most likely it's endothymos because the volume of the orbit is increased, so the eyeball will be sunken. And diplopia and ophthalmoplegia can happen most commonly due to soft tissue swelling or extraocular muscle entrapment. So if you're uncertain whether the diplopia is genuine due to UM entrapment, then you always have to confirm with a CT scan to see if the muscle is being entrapped by the bone fragment. Commonly, that could be infraorbital nerve numbness because they're anatomically located over the infraorbital rim. So when the bone fragment hit on it, then the nerve will be numbed. So periorbital bruising and swelling. So orbital fracture, give antibiotic. You've got to find eye doctors to rule any ocular injury. So entrapment of the extraocular muscle is urgent decompression because prolonged entrapment can cause muscle ischemia and fibrosis, causing future impairment of the eye movement. So optic nerve compression is also an emergency for urgent surgical decompression. Large defect will cause endophthalmos and vertical dystopia, and that has to be repaired surgically, either with a maple or a titanium mesh through various incision. So NOE fracture are uncommon as well. Nasal bone fracture, this one is very common. So X-ray could make diagnosis. So you can see there's the break at the nasal bone. So initially, because of the soft tissue swelling, you might not see the deformity. But if you palpate on it, then you might feel a snapping of the bone. So they have to be reduced. Otherwise, when the swelling subsides, the patient may notice a hump over his nose or a depression over his nose. And in those cases, you have to break it again and then put it back into the correct position. And that's much more difficult. So if the diagnosis is made and the nasal bone is placed, always offer reduction. At the same time, rule out septal hematoma as well. So previously we've mentioned why it has to be dealt with urgently. So nasal bone reduction is just a close reduction. It could be done under LA. Zygomatic arch fracture. So this is the zygomatic arch. So when it's fractured, it could compress on the mandible condyle, cause trismus, and that is the only hard indication for its reduction. Otherwise, the control problem could the patient could just leave it alone. If it doesn't affect the jaw opening, it could be managed conservatively. So the reduction is called a Gillies lift, where we'll open up in the hairline and put the elevator above the temporalis muscle and then lift up the zygomatic arch. So zygomaticomaxillary complex fracture is called a tripod fracture. So the clinical signs of it is down slanting canthus, because the cheekbone will usually be displaced downward and backward, causing a flattening of the cheek. There's concomitant orbital floor fracture causing the anophthalmos and eye numbness. So we have to start the antibiotic because the maxillary sinus is disrupted, and consult eye to rule any ocular injury in view of the orbital fracture. You will ask the patient not to blow the nose. So the treatment is ORIF. This showing the 4-point fixation, where the four patches of this bone is being fixed with screws and plates. So maxillar fracture. Maxillar fracture may cause airway compromise. The patient may need airway protection. It may cause malocclusion and change in the facial profile. So that is also called as Lafort fracture. So depending on the level of the fracture, they could be classified as Lafort 1 being a floating palate, Lafort 2 as a pyramidal type of fracture, and Lafort 3 is a craniofacial disjunction. So the last bit is the mandible fracture. So mandible, there are different parts of the mandible, from midline being symphysis, moving lateral body, moving up as the angle and ramus, and then the condyle. So for mandible fracture, the patient may complain of malocclusion. There will be trismus. There could be mental nerve numbness if the fracture line crossed the mental nerve foramen, and that there could be concomitant dental injury. This is an AP view facial X-ray. You can see clearly there's a parasymphyseal fracture on the left side, but X-ray is it's not very good tool to see the lateral structure like the condyle. But if you could appreciate on the right-hand side of condyle, the subcondylar region is also fractured. So another tool we could use is an OPG. Or we could proceed with an CT scan, because there are a lot of overlapping bone shadows of the mandible and the maxilla. So an X-ray may not be adequate for you to identify all fractures. So the aim of ORIF for mandible fracture is to restore the occlusion. So there are various ways to fix mandible fracture. This one is the intermaxillary fixation. It could be done under local anesthesia by the dental surgeon as well. So we will align the fractured mandible with the arch bar, and then we will lock the upper jaw and the lower jaw with wires and to maintain this occlusion and let the bone heal at its correct position. But it's contraindicated if the patient has a high aspiration risk. So otherwise, we'll perform ORIF to put in screws and plates to fix this mandible fracture. So I think these are the things you need to know about facial fracture as a MBCHB level. So any further questions? So if there are no further questions, the revision lecture will end here. Okay. All right.
Thank you.
So good luck for your exam.
Thank you.
Bye-bye.